to high resolution CRP 5.8, interleukin 6 elevated. What I need here is an anti-inflammatory drug. Did you ever check CRP? We do not check CRPs for our cardiac patients. Time we start checking CRP because inflammation is another marker. We have been hearing a lot about inflammation as a pathogenesis of diabetes. We need to understand that inflammation is a pathogenesis of lipidodysgenesis. So high resolution C-reactive protein can be brought down not by rosuvastatin but by colchicine. And after following up after 6 months and adding a curcumin, which is your haldi, these things have been shown by these 2 trials that I have given you. Results were good, no cardiovascular events after 2 to 3 years. Fifth case, I'll go a little fast, 52-year-old homemaker from Hyderabad, type 2 diabetes, 10 years, diabetic retinopathy, LDL 68, TG 380, very high, HDL 30. Small dense apoprotein A and LDL is what we are looking at. We are looking at the remnants of cholesterol. We prescribed fenofibrate, ezetimibe and saroglitazole. We got fantastic controls, 380 to 145, HDL 30 to 45, HbA1c is 8.2 to 6.8, and retinopathy stabilized. What more can you ask for? So what's important is to understand that these drugs are available in the market. Costs are 2,500 to 3,000 per month, 72% reduction, 47% reduction, 28% reduction, and I'm not discussing statin at all over here. So we need to sort of plan out an algorithm. We achieve our LDL first through a statin, then we assess what is the residual risk beyond LDL, and then we pick out the pathophysiology like Harrison says, and then we individualize the therapy based on the different markers that we have. And if we do that, we have a lot of drugs in the pipeline that will be coming in tomorrow like Vascepa, bempedoic acid. I think bempedoic was released. I've given a couple of bempedoic. I don't know if it's available today. We have obesity tariff. So those are a couple of the drugs. Few take-home messages. Residual risk is not something that we're discussing in conferences. It is very much there in our patient in spite of very good statinization. Indian drugs are available and cheap and they are going to give benefit. Don't look down on them. Be target specific, be pathophysiology specific. Start giving a combination of different non-HDL drugs and give them a better life. Some of the references here, some of the clinical challenges and implementation that we can discuss. I would leave you with this slide that we can optimize our patient. We mostly optimize with one, HbA1c, sugar, LDL and all. We get very good control. We optimize 2 or 3 risk factors, we get very good control. But we get real control when we optimize across the spectrum. So in short, it's a huge topic. I just wanted to highlight things. We need to go beyond LDL and see that there is a huge ocean of sharks sitting outside LDL and giving you a lot of trouble and biting you and giving you multiple problems in the eye, diabetes and cardiovascular area that we need to address as responsible clinicians, and I'm sure especially relevant to India, and I'm sure that would make a huge difference in our patient ecosystem for tomorrow. So again, I would like to thank you, the respected organizers, for this talk, and I hope we can change our prescription habits a little bit after hearing this. Thank you very much.
For speakers, any questions from the audience?
Sir, this is to Dr. Pratap, sir. Hyperglycemia and the patient experiencing nocturnal hypoglycemia with the normoglycemia, I mean fasting is normal and next day morning. How do you titrate the dose of insulin?
Morning hyperglycemia, if it is there, it generally ruled out nocturnal hypoglycemia. In the current era of longer acting basal insulin analogs, if you are using NPH insulin, then this may occur because it is the action profile of this insulin is like that. So if patient is on NPH, I will tell you to shift that to a longer acting basal insulin analog that will prevent nocturnal hypoglycemia, and at the same time the morning hypoglycemia will be covered better way. You can adjust the dose in a much better manner. So that is my message.
With normoglycemia, fasting is normal.
Fasting is normal and nocturnal hypoglycemia, you need to reduce the dose of basal insulin analog.
You need to reduce
it.
it.
Generally it doesn't occur. Fasting, when it goes below 90, the risk of nocturnal hypoglycemia is high. But if the patient is having normal sugars, fasting 110, 120 and still they are experiencing nocturnal hypoglycemia, this may occur with conventional basal insulin like glargine, which has got a peak at 6 to 8 hours, a small peak. I will suggest to shift them to a newer basal, ultra long acting basal insulin analog, either degludec or glargine 300.
Sir, Dr. Manoj sir.
Yes, madam.
The first example case which you showed was an Ida gasp with some 20 units.
That's right.
With so much of OHDs and around 52 years was not controlled with 14 HbA1c. Why do you want to change the drug and then do glucose monitoring?
So, no, this patient,
You had changed the injection to Glarlexi.
that was later, madam. So when we started the ICGM, this was later. So there are two different cases, right, which I showed you. There were two cases which I showed you, right? So the one which was the first one, which was on IDAGAS 20 units,
Yeah.
we at that time didn't make drastic changes. It's just that this patient was non-compliant, said himself that I'm not being taking it, and I would want to get more compliant. We put him on a CGM, and we saw the sugars coming down, because not because the medicines changed, because the patient started taking it. Patient himself said that I was taking it sometimes, missing out, not very serious with my dosages, and which is where the sugars had touched whatever, that 14%, as you said. So this patient later on, at the first instance, we didn't start a GLP for him. It was later on that we have shifted from IDAGAS to Glarlexi, because he wanted to then get into a little weight loss. So at each and every instance where CGM has been done, the first time the drastic reduction was purely because patients started taking the injection and the medications regularly and started following the diet as well.
Okay. If the same patient, as you say, is on CGM, is put on CGM, can we titrate with the same dosages and OHDs if he is adhering to the...
So two aspects.
diet.
I largely, if I understand your question right, your question is, why do you want to make changes in the medication if you're putting
Medications,
the
yeah.
patient on
Yeah.
CGM? Sometimes you may make changes in the medication because you don't agree with the kind of medications, and you have faith in other medications. So you may want to make that change when the patient sees you the first time. Irrespective of whether you're changing or not, the larger aspect there is monitoring. So for a patient who says, I will start taking it, I'll be more compliant, I want to follow my lifestyle better, again, we don't know how they responded. So I show you a drastic case. Everybody will not be like this who will come down from 40 units down, go into hypo. But there will be enough instances that when they start following, they can go into hypo. Of course, the larger part of the conversation was on those where a GLP or a dual was started. Their response is something which was unprecedented, and that now that it's officially available in the last 3-4 months, we are seeing a lot of those cases happening. Thank you.
Thank you, sir.
Anybody you can clarify this question. Recently, the glimepiride 2 milligram, metformin 500 milligram, oglibos 0.3 milligram.
Remove was banned.
They banned it. What is the reason? They are allowing glimepiride 2 milligram, metformin 500 milligram,
I
and
understand.
oglibos 0.2 milligram.
So no idea. I have no answer to this. I don't know if any of my colleagues have an answer.
Anybody can answer,
As
means I will
we have
be
to
happy.
we have to ask the CDSE or DCGI. Maybe if Professor Das was here, we could have asked him what would be the thought behind. Yeah, Alok has an answer.
I just heard it in some meetings, and this is what I feel. I may be wrong.
Sir.
See, Voglibos, these drugs are to be taken just 10 minutes after the food. They are not absorbed. They work.
They are allowing 0.2 milligram Voglibos with glimepiride and metformin. They are not allowing the 0.3.
Yes, sir.
So then what is?
2 milligram plus 500 milligram, 0.3 milligram, they are not allowing.
Sir, is right. If you are taking 3 milligram of glimepiride
Yeah.
and metformin, then 0.3 of Voglibos is allowed. But with 2 milligram of glimepiride, so that is the funny thing that
Yes,
we
yes.
don't know the
They
rationale.
are allowing 1 milligram, 500 milligram, 0.3.
Absolutely.
But 2
But 2
milligram
and 0.3 is
glimepiride, 0.3 they are not allowing. What is the rationale behind this?
The
one?
pharma
idea,
people
sir.
are telling, sir,
Brilliant
they
question, but
appealed
no
it to the
answer.
TCGI and they will get mostly to the above prescription soon. The pharma people are now telling that. They don't know how, what for they banned the drug. They return the clearance for these things and they are expecting it for clearance.
Sir, patients
Pharma
are
people are claiming that.
patients are so aware that, sir, you are writing a banned medicine.
Sir, but for that matter, many of us use 7.5 milligram of pioglitazone, and we were using it with metformin. Now they removed the 7.5 and metformin combination. So for many of your patients where you want to use it, you are using it separately and adding to the pill burden. So I really don't know the rationale behind some of those decisions. Right?
Thank you,
But
sir.
Great,
Thank you
great
very much.
question.
Thank you. Thank you. Thank you.
Actually, if you are supposed to take glimepiride or something like that, it should be taken 15 minutes before food. Metformin, rational, it should be after food. Voglibos, in between. So, combination will interfere the at least suboptimal effective dose you will not get with these three combination. That is why first time when glucored was introduced, there was a long debate. No one followed glucored. After 3 or 4 years only, second drug came following glucored. That is the reason, and maybe slowly 0.22 also they might withdraw, because the kinetics they will observe, the absorption erratic should not be more than 90%. It comes to 60 to 70%. That is why they have stopped.
So absolutely right, sir. I think the rationale that you explained was beautiful. It's just that, you know, the question here is they're allowing one particular dose combination and not, so which is what is baffling, right? And in any case, these combinations are only for convenience, sir. They are never ideal. All these combinations, most of them will have an insulin secretagogue and will have a sensitizer. So, you know, all our traditional learning was use this before, use the other one after. But when it comes to combinations, it is purely based for compliance and improving adherence. So,
So this is to highlight the fact that the phenofibrate and this thing, niacin. Sir, regarding this lipoprotein.
I didn't get the
Wonderful, wonderful. Actually, very happy to see the message that the only the niacin 1 gram per day for 1 year. Patient, actually cluster of patients, or group of patients, the family, they came with the lipoprotein for more than 100. All 3 patients. We have started on the niacin for 1 gram. They came after only 1 year. They are in abroad. Then all this from 100 it came to 35. I was very surprised. First time seeing from 100 to 35 lipoprotein little. But so that's what the point also mentioned by you. So I was really glad to share this information.
Actually, we have used niacin when I was doing my MBBS. We used to use it a lot at that time. And it is actually a very cheap and a very good drug. The only problem is in certain class of patients, because of flushing and palpitations, and some of them had loose motions, you know, people, for keeping commercially the patient happy, you end up stopping the drug because some people can't tolerate it.
Yes,
But
fine.
actually, I feel it is a very good drug, very cheap, very effective, and very powerful. But side effects are there.
Robust.
Very robust, but side effects are there. Many people can't tolerate it.
Thank you, sir.
Thank you very much, sir. No other questions, we will go for the next question, next session. Thank you.